Just a minute, ma'am. Just 1 minute only. Okay. We have on YouTube live. Okay. I'll just start. So all the faculty members are present. They have joined the meeting is or
Yes.
somebody has remaining.
No, everyone has joined except Dr. Pragya.
Okay. It's 1 minute only.
Pragya is needed later on. Let's start.
We can start. Everyone has joined.
Live. Okay.
Except one
Just
person.
start. So all the faculty members are present. They have joined the
Yes.
meeting. Somebody has remaining.
No, everyone has joined except Dr. Pragya.
Okay.
Pragya can join later. She is a panelist. Pragya is needed later on. Let's start.
We can start. Everyone has joined
Live. Okay.
except one
Just
person.
start. So all the faculty members are present. They have joined the
Yes.
meeting. Somebody has remaining.
No, everyone has joined
I'm
except
starting
Dr.
now.
Pragya.
Okay.
Pragya can join later. She is a panelist. Pragya is needed later on. Let's start.
We can start. Everyone has joined
Live. Okay.
except one
Okay.
person.
Now I'm starting. Okay. So all the
Guys,
faculty members are present. They have joined the
Yes.
meeting. Somebody has remaining.
No, everyone has joined
I'm
except
starting
Dr.
now.
Pragya.
Okay.
Pragya can join later. She is a panelist. Pragya is needed
Dearest
later on.
faculty
Let's
members.
start.
Okay. This
We
is
can
Nitesh
start. Everyone
Srivastava
has
on
joined.
behalf of Corona Remedy.
Okay.
Now I'm starting. Okay.
Can I
So all the
interrupt?
faculty members are present. Hello. They have
No,
joined.
you have two devices on.
remaining.
Please. No, everyone you have two
I'm
devices.
starting
Company.
I think
Can
some
can everyone get
Pragya
muted,
can join
please?
later. She is a panelist.
Pragya is needed
Dearest
later on.
faculty
Let's
members.
start.
Okay. This
We
is
can
Nitesh
start. Everyone
Srivastava
has
on
joined.
behalf of Corona Remedy. Now I'm starting. Okay.
Can I
So all the
interrupt?
faculty members are
voice band
Hello.
कर देना.
No, you have two devices on. Please. No, everyone you have two
I'm
devices.
starting now.
Company.
I think
Can
some
can everyone get
Pragya can
muted,
join
please?
later. She is a panelist.
Pragya is needed
Dearest
later on.
faculty
Let's
members.
start.
Okay. This
We
is
can
Nitesh
start. Everyone
Srivastava
has
on
joined.
behalf of Corona Remedy. Now I'm starting. Okay.
Can I
So all the
interrupt?
faculty members
voice band कर
Hello.
देना.
No,
Yes.
you have two devices on. Please. No, everyone you have two
I'm
devices.
starting now.
Company.
Can I start,
I
ma'am?
think
Can
some
can everyone get
Pragya can
पहले
join
पहले सब
later.
लोग
She
म्यूट
is
हो
a
जाओ
panelist.
बहुत
Pragya is
ज्यादा
needed
Dearest
later
chaos
on.
हो रहा
Let's
है.
members. Okay. This
We
is
can
Nitesh
start. Everyone
Srivastava
has
on
joined.
behalf of Corona Remedy. Now I'm starting. Okay.
Can I
So all the
interrupt?
faculty members
voice band कर
Hello.
देना.
No,
Yes.
you have two devices on. Please. No, everyone you have two
I'm
devices.
starting now.
Company.
Can I start,
I
ma'am?
think
Can
some
no
can
no
everyone
please
get
please
can
पहले
join
पहले सब
later.
लोग
She
म्यूट
is
हो
a
जाओ
panelist.
बहुत
Pragya is
ज्यादा
needed
Dearest
later on.
chaos हो रहा है.
members. Okay. This
We
is
can
Nitesh
start.
Srivastava
Everyone
everybody
has
on
joined.
अभी
mute mode.
मेरी
I
बात
have
किसी
Corona
को
Remedy.
सुनाई
Now
पड़
I'm
रही है?
starting. Okay. I have kept everybody on mute
Can
mode,
you
ma'am.
guys
voice
listen
band
me?
कर देना.
No,
Can
you
you
have
guys
two
listen me?
Yes, ma'am. You
devices
are
on.
audible.
Please. No, everyone you have two
Please
I'm
devices.
keep
starting now.
quiet. It is
Can
very
I start,
chaotic.
I
ma'am?
think
Can
some
you no
Can
no
everyone
please
get
please
can
पहले
join
पहले सब
later.
लोग
She
म्यूट
is
हो
a
जाओ
panelist.
अभी
Pragya is
यार
needed
न्यू
later
यूजर
on.
हो रहा है
Members.
सब
Okay.
लोग.
This
We
is
can
Nitesh
start.
Srivastava
Everyone
everybody
has
on
joined.
mute
अभी
mode.
मेरी
I have
बात किसी
Corona
को
Remedy.
सुनाई
Now
पड़
I'm
रही है?
starting. Okay. I
Can
have kept
I
everybody
interrupt?
on mute
Can
mode,
you
ma'am.
guys
voice
listen
band
me?
कर देना.
No,
Can
you
you
have
guys listen
two
me?
Yes, ma'am. You
devices
are
on.
audible.
Please. No, everyone you have two
Please
I'm
devices.
keep
starting.
quiet.
Anuradha,
It is
Can
very
I start,
chaotic.
ma'am?
ये सब muted
No
can
no
everyone
please
get
please
can
पहले
join
पहले सब
later.
लोग
She
म्यूट
is
हो
a
जाओ
panelist.
अभी
Pragya is
यार
needed
न्यू
later on.
यूजर हो रहा है
Members.
सब
Okay.
लोग.
This
We
is
can
Nitesh
start.
Srivastava
Everyone
everybody
has
on
joined.
mute
अभी
mode.
मेरी
I have
बात किसी
Corona
को
Remedy.
सुनाई
Now
पड़
I'm
रही है?
starting. Okay. I
Can
have kept everybody on mute
Can
mode,
you
ma'am.
guys
voice
listen
band
me?
कर देना.
Can you guys listen me?
Yes, ma'am. You are audible.
Please. No,
Hello. Hello.
Hello. Now the background noise has
Hello.
gone. I think those who have logged with two devices, please log in with only one device. And I
Okay.
think now it's all the background noise has gone.
And don't speak, just chat.
Yeah.
Hello.
please start.
Okay, everybody is present now. Shall I start?
Yes, please go ahead.
Okay. So, good evening, everybody. Good evening, esteemed faculty members. Okay, so on behalf of Corona Remedies, I, Nitesh Srivastav, welcomes all delegates and faculty members on this Insight series and evening with Isarians. Okay, so we have Dr. Seema Pande, okay, with us. Dr. Seema Pande is MD, FRM, FICOG, FICR, DIP in USG, Fellow in Minimal Access Surgeries and Regenerative Medicines, Director and Chief Consultant. So, Dr. Seema Pandey is President Azamgarh Ops and Gynae Society, Librarian ISAR 2024-2026, National Executive Committee, Member ICOG 2024-26 and ISPAT 2021-25, Commonwealth Association for Health and Disability. She is co-author A to Z of PCOS, everything you wanted to know about PCOS. Also, she is co-editor ART and Fertility Enhancing Surgeries, the Synergy, Ovulation Induction Simplified, POXI Handbook of Drugs in Infertility, POXI Focus Preterm Labor. She is reviewer in Journal of Obstetrics and Gynecology India, and she has key interest areas are infertility and reproductive endocrinologies, PCOS, adolescent health, and early pregnancy failure. She is spreading awareness about the PCOS and adolescent health among rural women and school girls through health checkup camps and talks through her NGO Surbi. So I welcome Dr. Seema Pandey.
Thank you, Nitesh, for your kind introduction. Good evening, Isarian, and welcome back to season 2 of An Evening with Isarian. This time it is called Insight series. The meaning of insight is during this journey, we are going to. Nitish, can you just remove my. Can you stop sharing
Yes,
your
ma'am.
screen, please?
Yeah.
During this series, we are going not only to learn but unlearn and relearn things which are good in our practice. And this Insight series and evening with Isarian is going to be held on third Friday of each month. And we are as our previous series, we are going to go with different states in this journey of ours, where we'll be meeting new Isarians in each and every meeting, and we will get so much insight from the people who are doing excellent work. Our guest of honor, Dr. Sujata Khar, is taking some time in joining us. Till then, I will hand over to this platform to Dr. Anuradha Khar, who is going to start this academic session first by evoking the our deity Ma Saraswati. Thank you so much, and thank you, Core Connect.
Good evening, my dear Isarians. First, we would start any program and could we have the lighting, please?
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः.
Thank you, Anu. I wanted to introduce Dr. Anuradha Khar. Can I get her CV, please?
Yes, ma'am.
As you all know, Dr. Anuradha Khar is my best friend. So, apart from that, she is director and chief consultant Nurture Clinic.
Learning And every
and
day we are
currently
learning.
practicing infertility and infertility related endoscopy. Dr. Anuradha is honorary treasurer Karnataka chapter of ISA 2023 to 25, member managing committee National ISA 24 to 26, and she is a fellow in reproductive medicine and she got many awards to her credit like Foxy Badlav Award, and Dr. Anuradha has written multiple articles and authored several chapters in several books. Welcome, Anuradha, and please start the academic session now.
So first slide back. So hi Siri and experience. A warm welcome to all these skilled
I think your network is unstable. Just stop your picture and then speak.
Am I audible?
Yes, so you are on waiting room.
I'm audible.
Okay, just a minute.
Audible.
Is there some problem?
I think there is some network connectivity issue from
Okay,
Archana ma'am's
okay,
end.
okay, okay. So please, we will start with our first talk. Can I get the CV of our speaker till Dr. Anuradha is joining? I will introduce the speaker.
Yeah, sure, ma'am.
Excuse me, can you please see if people are able to join? Because some of our fellows are texting that they're unable to join the webinar.
Okay. And technical
Till
team,
till
please have a look into it.
till now nobody is on waiting room. Okay, everybody has joined. Okay, nobody is on waiting room.
No, not on faculty link. We
Not
are
on
talking
faculty.
about the other link, general link for the audience.
Okay, we are looking on it, ma'am.
Okay.
Till then, I'm sharing the CV of Dr. Manjunath sir. Okay, our speaker.
Yes.
I think before that, the chairperson has to be done, right?
Yes, exactly. So chairperson, we have Dr. Shahnaz. Then just a minute, I'm sharing her CV.
Please, you just share the CV. I will introduce.
Yeah.
If Dr. Anuradha is not able to join. So today we are going to deal with tubal factor infertility. And in this insight series, we are going to take one topic at one webinar. And first is tubal factor. And for this, our speaker is Dr. Manjunath. Before I welcome Dr. Manjunath, I would like to welcome our esteemed chairpersons. First, Dr. Shehnaz Tariq. She is ex-professor and head of the Department of Gynae and Ops, GMC Srinagar. Ma'am is president of SOX conducted and she has conducted first ever UA Foxy conference in state of J&K in 2025. Madam is ex-executive member. Welcome, ma'am. Our second chairperson for this talk is Dr. Vanita. Please, can I have the second CV? Dr. Manita Metgood. Madam is medical Medical Director, Care Center for Assisted Reproduction and Endoscopy. Madam is pioneer in infertility and ART with more than 25 years of experience. She is specialized in training in ART in Australia and US, Singapore. Madam is certified for first test tube baby of North Karnataka in way back in 1997. Madam is also founder president Belgavi Menopause Society 2022-24. She is chair fertility and aging committee IMS 24 to 26. Madam is patron member of PCOS Society, EC member Karnataka chapter of ISAR, member of INSERG and president of OBGYN Belgaum 2008 to 10. There are multiple awards to her credit like State IMA BC Roy Award 2017, ISAR Dronacharya Award 2024, IAG Torchbearer Award, Eastern Award for Iconic Women of the Year 2020, Bangalore, Dr. Maheshwari Award, AICOG Kochi 2007, and Kittur Utsav by Government of Karnataka Award in 2024. I welcome you, ma'am. And I would like Dr. Vanita or Dr. Shehnaz to introduce our speaker, Dr. Manjunath, please.
Am I audible?
Yes.
Madam, keep it for only for 2 lines.
Am I audible?
Yeah, ma'am, you are
Am I
audible.
audible?
Yes, ma'am, you are audible.
Yes, ma'am, you are clearly audible.
Yeah. Thank you. Thank you, Dr. Seema, for your kind introduction. A very good evening to all dear Izarians, and I congratulate the organizers, Dr. Seema and Dr. Anuradha and Dr. Sujata for this great initiative about Insight series. And today's talk is on evaluation of fallopian tube. And it's my great privilege to introduce our own colleague, Dr. Manjunath CS, eminent faculty. And after his post-graduation, he has done his fellowship in gynec endoscopy in RGUHS and master's in reproductive medicine from Horton University, London. And presently, he's a medical director, Baby Science IVF Clinic Private Limited. He has more than 15 years of experience in laparoscopy and fertility. And he had served as a chairperson, Karnataka chapter of ISAR 21-23, and I was
Excuse me, ma'am,
yeah
short.
we worked with him. It was a great pleasure. He's a great academician, and he holds many key positions in many societies, and he's passionate about his teaching experience. He has trained about more than 140 gynecologists in laparoscopy and infertility. And he has social activities also. And he has been invited speaker in national and international forums. He has contributed many chapters in infertility and gynec laparoscopy books. So his special interest is regenerative medicine in infertility, FET, and mild ovarian stimulation and hysteroscopic surgeries. So with this kind introduction, I just request Dr. Manjunath to take over the proceedings.
Can I be allowed to share my screen?
Yes, I think.
Yes, sir, you can.
Okay. Good evening and warm welcome to everyone. And thanks for Dr. Seema and Anuradha to start this Insight series. I know both of them are very keen to include as many people as possible and spread the knowledge. I think now it's able, you are able to see my screen?
Yes,
No,
sir.
not at
It is Zoom.
Zoom is coming in front of, sir.
Now?
Right now, only Zoom we can see on your screen, sir.
I think you have to share your slides.
Share your slides. Sorry, I'm back. Okay.
Okay, 1 second.
There was some internet glitch. Share your slides, please.
Now,
Not it, sir.
Anju, you are sharing your web wala. Just share your Microsoft या जिसमें भी your talk is there. This is Google you are sharing.
now is it visible? No.
No, no,
No,
sir.
no, no. You stop share and do it again.
Sir, open the PPT. Maybe.
Sir, if you are unable to share the slide, what you can do, you can just share your slides on my mail ID. I'll just share from my end.
Okay, fine.
I'll just WhatsApp you my email ID. You can just share, then I'll download your PPT and just share.
1 second, I will just.
It should be a
It
problem.
is there. You
Yes,
can
yes,
yeah.
yes,
Right now?
Manjunath,
Yeah.
I think
Yeah, it
Just
is
please
there.
slides
keep it
are
on
visible.
slideshow mode.
Yeah. Now it's visible?
Yes, sir.
Yeah. Thank you so much. Okay. With this, thank you for and special thanks for both of you to include me in this Insight series. I'm sure this will benefit lot many people. Thank you so much. Today's topic for me is a review of tubal factor in infertility. We all are born out of this hollow tube, including me. What people assume when we say fallopian tubes. Let's have a match the following. First picture on the left side is a common people. The second one is a radiologist, and the third one is a general obstetrician.
Manjunath sir, can I just interrupt? Actually,
Yeah.
many people are texting except us, the faculty. Nobody has joined the webinar.
Oh, okay.
Mahesh Korgal sir also has messaged in the group that they're unable to join. Our
Uh,
fellows also.
Somebody from the technical team can help them.
Code Connect. What is going on? Let me talk to them.
We have already, yes, ma'am, we have already shared the link and everybody can join from that link. Delegate link is already shared.
But they are saying they are not able to. Your YouTube, can you see people, anyone have joined? And please help Dr. Mahesh to join the series.
Six,
I think that is problem.
six,
Problem could
six
be at his
delegates,
end.
six delegates on YouTube. They are watching.
Okay.
Okay. We can see 6 delegates.
So
Right.
this is network issue.
Yeah,
It might be.
YouTube is working, but the live webinar link of Zoom that was shared to everybody till yesterday, they're unable to join through that. So we have to
Check.
reshare the YouTube link.
We are checking it, ma'am. We are checking it, ma'am. Just allow us some time.
Yeah, many people are unable to join it.
And help Dr. Mahesh to join, please. Huh?
Yeah, sure, ma'am. We are doing it.
Dr. Manju, can he start right now or should we wait? I think Dr. Manju, you you start.
Okay.
People can watch it afterwards also. Fine.
Sure.
Otherwise, it will look very interrupted.
Correct. So, what the people assume compared to a layman people, the radiologist, and the obstetrician, when we say them a fallopian tube, they assume different things. So, I think all of you know that the common people think that fallopian tube is just a rigid tube, like one side there is an input, one outside, one other side is an output. And a radiologist thinks it's maybe a flexible tube, and that's how he's only concerned about only whether the tube is patent or not. That's not more than that. And many obstetrician also thinks that it's just a tube which is having a more flexibility. That's how they think. But as a reproductive medicine specialist, should we view fallopian tube differently? Definitely, yes. We should view a fallopian tube in a different way. When we are evaluating the tubal factor, it should be done in toto with all other factors. It should never be considered as a single alone factor affecting the infertility. As you all know, tubal factor is the one of the most common causes for infertility, accounting up to 30%. And tubal evaluation is a must once you decide the couple to put on some kind of intervention treatment. Means to say, when the young couple are coming and you want to do just simple ovulation, considering our ovulation is good, the sperm factors, everything is good, you may not jump and do any kind of tubal test for 1 or 2 cycles, maybe 3 cycles. But once you decide, okay, they are having a long-term thing, or if you are planning for an IUI, some kind of intervention, that's when you need to document the tubes are patent. That's when we need to do some kind of evaluation to check whether the tubes are patent or not. As you know, that tubes are not just a tube. It helps in 4 functions majorly: the transport of the sperm, transport of the eggs, and transport of the fertilization, and more importantly, nourishing the embryo and facilitating the fertilization for first 4 to 5 days of the embryo life. So it's just not a tubus, it's a rigid tube. It has so many cellular lines with cilias. And if you go towards ampulla, that complex structure becomes even more delicate, and the more folds in the mucosal things which start appearing towards the ampulla. The oviduct guides the sperm ascent by the way of 3 mechanisms. One is rheotaxis, thermotaxis, and the chemotaxis. In this beautiful figure is trying to explain to you all these 3 so-called mechanism of how the sperms are transported. This is not just the sperms are transported just because it has motility. Tube plays very important role in transportation of the sperms to the site of fertilization. So that mechanism is thermotaxis, chemotaxis, and rheotaxis. Rheotaxis is just the after the sperms are activated, the hyperactivated sperms start beating its flagella asymmetrically. That's how they get faster mobility against the current of tubal fluid. The tubal fluid will be flowing in a different direction, and the sperm has to travel against the stream, against the current, and to reach the oocyte site. So only a good sperm can able to reach the fertilization site. As you all know that out of millions of sperms, only few hundred of sperms will reach the fertilization stage. That's because this sperm means the tube has a natural selection method along with the other entire female genital tract. And it's wonder to appreciate the thermotaxis mechanism also, because there is almost 1.5 to 2 degrees centigrade difference between the isthmus and the fimbrial end. So after activation of the sperms, because of the special receptor on the sperms can able to differentiate 1/100th of centigrades of the temperature difference. So that's how they are attracted towards the high temperature site, that is towards the ampulla, ichthymoampullary junction, where the fertilization will happen. And the chemotaxis, again, the cumulus cells which are attached to the oocytes will start producing the progesterone, which has chemotactic attraction, attract the sperms by chemotaxis mechanism. So they basically, the fluid which is secreted in the tube is viscoelastic thing. Its secretion rate is around 1 to 3 ml per day, that is 24 hours. So that's how it is increases towards the ovulation time and decreases after that. So that's how the actively the tubes are involved in the sperm movement and the selection. It's not only that, this particular study which has compared how the normal morphology and the pathological sperms will reach the ampulla according to the age. If you see this, the blue line is 20s, 30s, and 40s. The normal morphology sperms, the amount of normal sperms reaching the ampullary site will decreases with age. The green one in 40s, the amount of the sperms which is going to reach, even though amount and the quantity of the sperm, the speed of the sperms are normal, the amount of the sperm reaching the ampullary stage in 40s is quite decreased compared to 20s and 30s. So that's how the active participation happens from the tubal side in transmitting the sperms. So even in the graph also you can see the percentage of the sperms reaching the ampullary site decreases, and also the pathological sperms reaching the ampulla increases with the age. So not only the sperm, now it helps in, it guides in the fertilization also. We all know the fluid viscosity and with all its components facilitates the fertilization, promotes the recognition of sperm and egg, and some kind of muscular contraction of the fallopian tube also facilitates this fertilization. The influence of the embryo, it also influenced by providing the good nutrition during that 4 to 5 days of early development. For example, during the early development of the embryo, it requires oxidative metabolism where the pyruvate and the lactate are used. Towards the end, 4th or 5th day, once the embryo attains the long active mitochondria, then it will switch to glycolytic metabolism where it requires little more oxygen and more glucose for their metabolism. So it knows, the tube knows when to provide, what to provide. It beautifully synchronizes everything during that 4 to 5 days of embryo development. It's not only that development, the tubes also protects the embryos from its stress. Yeah, as you know, any kind of glycolytic metabolism, there is increased oxidative stress on the embryo, and it will start releasing so many free radical, oxygen free radicals. So that can be neutralized both by enzymatic antioxidative method and non-enzymatic antioxidative method, like producing heat stress heat shock proteins, so that it will have a suppresses the more oxidative free oxidative molecules. Also helps in embryo after the fertilization, after 4 to 5 days, it helps in embryo transport towards the uterus, and which is mainly influenced by the amount of estrogen and the progesterones, are mediated by the estrogen and the progesterone. The estrogen positively influences more muscle contraction, increases ciliary beating frequency, increases fluid secretion and flow. Progesterone will decrease the muscle contraction and helps in relaxation and decreases the ciliary beating frequency. So more of estrogen will transport those embryos back into the uterus. Not only this fluid mechanism, the muscular contraction, there are some kind of gas inside the oviduct which are helpful, which are very much required. As you know, the oxygen, even in vitro culture also, the embryos are best grown at 5 to 6 percentage. The other two gaseous molecules which are important for embryo movement are the hydrogen sulfide and the nitric oxide. There are fine interaction between the oviduct and the embryo during the development and the transport. One example I would like to highlight here is the initial embryo requires small amount of hyaluronidase, but if it is increased hyaluronan acid, that is a damage to the embryo. So that is overcome by producing the hyaluronidase 2 molecule from this oviduct, which will neutralizes excess hyaluronic acid inside the tube around the embryo. That's how the fine interaction happens between the oviduct and the embryo. And this same physiology, at least in bovine studies, they have seen by adding hyaluronidase 2 enzymes into the embryo culture has produced more embryo compared to not adding this particular molecule. So oviduct is not just simply a tube; it should be considered as like a four important mechanism for the fertilization, and along with the protection, providing protection, nutrients, and controlling even the epigenetic regulations by avoiding the external stress on the embryo. Aging, as I was discussed in one of my previous slide, has a great influence on the fallopian tube function, like how it affects other reproductive organs like ovary, uterus, the cervix, everything. So as the aging increases, the both all three parameters, biological, physical, and morphological changes are induced into the tube, especially the tubal ciliated density keep decreasing as the lady ages. So one of this particular study has compared the tubes in the 20s, 30s and 40s. These ABCs, 20s, 30s and 40s. The tube length shrinks, the morphologically it modified. Even the lumen in 20s, it is having increased ciliary things and increased folds will keep reducing in 30s and 40s. So that's how the morphological changes happens in the tube. Not only morphological changes, including the pro-inflammatory cytokines, the extra importantly, as the ladies age, not only the ladies, any person ages, the extracellular matrix will the component of the extracellular matrix keeps decreasing. That's how we all get stiffness and decrease elasticity thing of kind of thing. And as I was stressed, there is decreased or impaired ciliary beating as the woman ages. This is particularly again a part of that particular study where they have compared the various morphological changes in 20s, 30s, and 40s. Particularly, what you need to observe is the decreased mucosal area is greatly reduced in 40s. That's how. That's why the fertilization. One of the factor where the fertilization will be less in case of increased age. Even the ciliated density decreases. The elasticity will decreases. Coming to the tubal evaluation, we have commonly used four things which we use for a tubal evaluation: traditional HSG, laparoscopic chromoperturbation, sonohysterosalpingography, what we call as SIS, ICOSY. Few of that thing which are coming up, maybe in future we'll have more answers for this. The MRHSG, transvaginal hydrolaparoscopy, and the CAT, chlamydial antibody test. Let's see few means few more in more detail about these tubal evaluation methods. HSG is still a first modality where you all know how the HSG is done. Urographin is injected transcervically and either fluoroscopy or X-ray is used to capture the films. So the pitfall of HSG is it has approximately 60% sensitivity and 90% specificity. So what is this means? When it is says patent, specificity is 95 to 98%, means it's more or less definitely it's patent. But when it's blocked, then when the sensitivity is it's hardly 55 to 60%. So we need to confirm by doing any other methods. We cannot rely only on HSG when it says it's a tubal block. So especially true for a proximal tubal occlusion. Basically, it happens because of tubal spasm, because most of the HSCs are done without anesthesia. Even in case sometimes with anesthesia also, there can be a proximal tubal occlusion, PTO. PTO is usually bilateral. Sometimes it can be unilateral. So if there is a PTO, either it should be the HSC should be repeated, preferably under GA, or you do a fluoroscopic guided cannulation and or hysteroscopic selective cannulation can be done to confirm whether it's truly blocked. Most of this PTO block, as I told, it's maybe because of the spasm or a simple mucus plug by hysteroscopic cannulation or a fluoroscopic guided cannulation can solve this particular entity. And the reward what we get by solving this is huge, because after this at least 70-80% will conceive either naturally or by IUI. We all need to change the way we are looking the HSG. We should not look how the radiologists look HSG. For radiologists, it's only a patency is more than sufficient. Not so when we are a reproductive medicine specialist. We should go in detail, especially if you do a HSG with a fluoroscopic guided. You can see a lot of picture from the initial stage to the last stage. Initial stages, we need to start observing the mucosal fold. One of this picture you can see here, the fimbrial mucosal folds are clearly seen, which is basically categorized into category 1. Then if there is a clumping of those folds and a mild sacculation kind of thing, then we call it as a category 2A. And then this is, even though there is a patent tube, there is mild ampullary dilatation, which is called as, which can be categorized into category 2B. The fourth one is obviously category 3. So this category 2B, even though category 2A, to some extent, okay, we can still go ahead and do and try naturally or an IUI. You can expect a good result. But category 2B are with a decreased result. And of course, category 3 are will not give you any good results in case of natural or IUI pregnancies. So as I told, laparoscopy is usually not the preferred one or a preferred first line of tubal evaluation, but this is considered as gold standard because we can evaluate the tube in a more or less a complete way, where we can see peritubal adhesions apart from the patency, whether it's a sacculated, whether it's kind of mild hydrosulfings. All those things can be evaluated, but of course it's invasive, more invasive than the HSG, and it's preferably for kept only for a long-standing infertility, or if it is associated with some kind of adnexal pathology where you want to treat even that adnexal pathology, then you can go ahead and do a laparoscopy as a first line. Otherwise, generally the HSG, if there is any doubt in the HSG, then the laparoscopy is preferred. So this particular study compared the reliability of HSG versus laparoscopy. We can clearly say that for uterine cavity, compared this HSG with hysterolaparoscopy. Usually laparoscopy are combined with hysterolaparoscopy. So they say that reliability is more for a uterine cavity of HSG. But when it comes to the peritubal abnormality, the HSG is not so reliable compared to laparoscopy. That's the very known fact. So coming to the SIS, saline infused sonohysterography, it's a convenient where there is no radiation exposure, and this can be done as an OPD procedure in your as a just like a office hysteroscopy. It gives an additional information about the endometrium and endometrial cavity. It's very good for polyp detection, everything. But only thing is, if there is no high resolution scans, we cannot clearly make out which side of the tube is patent. Now, if you combine that with the 3D reformatted images, then maybe the SIS can be used widely, and it can give even more accurate picture. And preferably, this should be done between 4 to 10 days, as we are advising for HSG. The one more method of evaluating the tube is salpingoscopy, not used widely because again it's an invasive procedure. Currently, the salpingoscopy requires either laparoscopy or laparotomy, because it's basically passed through the fimbrial end to view the entire tube from the fimbria to the isthmus. There are few studies where they have studied transcervical salpingoscopy also, but still not in a wide use. The next one, which is picking up in at least in Western countries, is ICOSY, hysterosalpingo contrast sonography. This has little more advantage of studying the entire morphology, the trajectory, the speed with which the contrast will go, the intrauterine pressure, the intratubal pressure, the encircling of the fembria. All those factors close to the laparoscopy we can find using this HICOSY method. It has become, as I told, it's becoming more like first line of recommendation in many of the Western studies and Western countries. Sensitivity and the specificity as ICOSY is much more compared to HSG. In combination with 3D, even more better pictures we can get, and we can get into the complete angles, everything, and then maybe we will be having a better picture about the tubes and the uterus if you use the HICOSY. Chlamydia antibody test, just to mention, as you know, the commonest PID is the chlamydial trachomatis and Neisseria gonorrhea. Many studies are demonstrated that a severity of the tubal damage can be found out by doing the titer of IgG chlamydial antibody. Several European studies recommends that, okay, you do that chlamydial antibody test. If it is positive, then go ahead and do some kind of tubal patency. If it is not negative, may not be required. But this antibody test is not so widely used in US and India, in India particularly, because they say that many people are already infected with chlamydia and chlamydia. So by doing a test, we cannot differentiate really between the affected tube and the not affected tubes. So with this, I finish, and I once again thank Dr. Seema and Dr. Anuradha Khar for giving me an opportunity to be with you guys. Thank you so much. And I'm happy to take any questions.
Thank you so much, Dr. Manjunath.
Nice presentation, Dr. Manjunath. Appreciate.
Yeah.
Thank you.
So it was a very, very
New
excellent
concepts.
presentation with crisp points delivered. Now, I have one question, Dr. Manjunath. HSG, we know, is now being replaced by salpingosonography. For the matter that HSG is more painful than SIS, that is the main reason which is cited. And if a good sonologist or reproductive medicine, like we do scans every day, so if a trained person does the scan and that vaginal probe, I think it is not so difficult to find out the fluid coming out of the tube.
Okay.
I think HSG best for years. Take on that.
Dr. Anu, I think I didn't hear anybody heard Dr. Anu what she is asking or anything. The saline is saline sonography. As
I am audible now.
yeah. Yeah.
Okay, I want to ask you that now this is quite painful. If you talk.
Correct. See, as I mentioned that if the resolution of the scans are good and if they are trained properly, so no, saline infusions, histosonography is very good actually. It's easy, handy. We can do it in the OPD, finish it within 10-15 minutes. The procedure get finished, and even the patient feels more comfortable compared to HSG. But that kind of many people are still not able to do this SIS because many people don't have this kind of high resolution scans and they don't have that skill. So majority of the patients are subjected to HSG. So that's the thing.
Can I add one point? Something, Dr. Manju?
Yeah, ma'am. Go ahead.
Yeah, with this SSG or SIS, the best thing is now you don't have to rely on the looking at the flow coming through the ostia. That is done by our color flow. anything,
Yeah.
any
Yeah.
moving liquid has a very beautiful
Correct.
color splayed, and that is the way how do we diagnose patency in SSG nowadays with upper machines which are having good color flow. So that
Correct.
is
Correct.
one thing. And Manju, I must tell you and congratulate you that this was another aspect, the way you dealt with this fallopian tube talk, tubal factor. This was amazing. The points you have risen, those are wonderful.
Thank you. Thank you.
Chairpersons, if you want to say, and Manju, please stop sharing so that they can see you.
Dr. Manjunath, I too have one question afterwards.
Somebody is unmuted. Please mute yourself.
Hello. Can I add one point?
Yeah, Dr. Shilpa, go ahead. Go ahead.
Yeah, with SSG, we can continue the stimulation and the same cycle, we can give the treatment for the patient. Unlike HSD, we cannot take up that cycle. The patient has to come next cycle. So that's another advantage of doing sonosalpingography.
Yeah.
Dr.
Dr.
Manjunath,
Archie wanted
I
to
have
ask.
one question. As we have discussed a lot on HSG, and it was really very beautifully taken. You have talked about 2A, where the circulations are present
Yeah.
on HSG, you see. So, how to counsel the patient and what exactly, because the patient has come from a radiologist and there it was written only the tubes are patent. So, when it comes to us, we see circulations are there, and how to make the patient understand that there is some problem. They say, okay, we have come from 10 doctors and nobody has pointed out this and you are only doing this. How to proceed in this?
That's the very common thing which we get, because the radiologist or any other doctors would have told, okay, your tubes are good, patent, good and dry. But they come and sit in front of us, when we see that, okay, your tubes are good, but that's not, means tubes are patent, but morphologically your tubes are not that good. I would say that, okay, it's like a tube which is open, but function wise, they may not do what is it required to do. So morphologically good means structurally good, but function wise they are not that.
Functional.
So that's how I tell them. But I won't tell them that, okay, I will not discourage them to not to go for IUI or an IVF. I will say maybe 1 or 2 cycles you try. If it doesn't work out, please move ahead with other higher modality rather than sticking to IUIs. So that's how I counsel them.
Thank you. Thank you so much.
Dr. Rashi, you took my panel question.
Sorry, ma'am.
Okay. Okay.
Any more
Dr. Manjunath,
questions?
it was an amazing presentation with the many eye-opening informations on tubal functions and the natural fertilization. And it was a real insight into the tube and a key role of a fallopian tube in fertilization.
Thank you.
Thank you very much. It was definitely useful for all the delegates and for us also.
Thank you so much. Thank you so much.
Hello. Dr.
Hello.
Senas, you have any remarks to tell
That is
us?
what am I audible?
Yeah.
Yes,
Yes,
ma'am.
yes, you can speak, ma'am.
You see, what for me, no doubt it was a beautiful presentation in detail and depth. But one thing is, ma'am, which was very surprising for me personally, that not only X, it is the tubal function which gets, impaired with, aging process. This was very surprising to me. I never knew about it. So it was a
Yes,
piece
yes.
of information which I came to know. Another thing which I would like to know, that once we are doing haiku, or Sion test, which is called, you see, it can tell us indirectly that the tubes are patent once there is accumulation of fluid in the pouch of Douglas. But how do we know that whether both tubes are open and it's not only the uh, only one?
That's how as Dr. Seema was
We
mentioning.
do color
So
Doppler.
if you have a high resolution, you can make out, or you can, if you put a color Doppler, as the fluid is flowing, we can make out whether the tube
Okay.
is open or blocked.
Okay. And what is your criteria once patients come to you? On what grounds do you, assess that we should go for invasive testing like diagnostic lapro and histro, or first go with the HSG or sono haiku?
Basically, I always do if they're young, lesser than 5 6 years of married life. If they're young, my first one is HSG. I won't suggest more invasive things. And as I told before that, as I told, if they are very like just hardly 1 year, 2 year married life, they are young.
Better to do HSG.
Even without doing HSG, put them on ovulation induction, provided we are just doing ovulation induction and timed intercourse. If I decide them to take them for IUI, then when suggest them an HSG. And but in case if they are a long-standing infertility or there is some
Age
kind
factor is there, and
of
then
any other factor is
without
there, then
wasting
maybe I
time,
will
you would
suggest
like
for
to
the
do, yes.
laparoscopy.
Wonderful, wonderful.
Or
It
if
was
they have done
lovely,
already
lovely.
ovulation cycles
Correct.
outside, many a
Correct.
times those patients come. If
Correct.
they have done 3 4 cycles outside, better check their tubes first. That also is a
No, it was the
presentation
method of
which
Manjunath,
we
testing
are
the
there any?
tubes, it was the method of testing which we should choose. Long-standing infertility, age factor, better directly go for interventional. That is lapro and histro.
So any more
Dr.
questions,
Manjunath,
or
are
should
there
we?
any evidence-based guidelines, recommendations for laparoscopy and other interventional procedures?
Nothing like that, madam. Nothing like that.
Nothing like okay, okay.
So we'll move on now. I think we are done with questions.
Thank you.
Yes.
So thank you, Dr. Manjunath. Thank you, Dr. Vanita, Dr. Shanaz. Thank you so much for joining in, and
Honored to be a part of this
thank you so
prestigious.
much. So
Yeah,
we
we're
move on.
thankful.
Thank you,
So
Dr.
we
Vanita and Dr. Shenaz.
Thank you,
Thank
thank
you
you,
so much for the
thank you.
so
opportunity.
now, yeah. So now we move on into panel discussion. We are all waiting. We have our experts, Dr. Sadhna Gupta. Can we have her CV, please, Dr. Sadhna Gupta? So the topic is impact of tubal factor on fertility, and we are doing case-based scenario. So it's an honor to introduce Dr. Sadhna Gupta, who is director and senior consultant of Jeevan Jyoti Multispecialty Hospital and Research Center. And she is presently ICOG Vice Chair elect 2025, Central Executive ISAR committee member, ISOPAB member, President North India Gynec Forum, present Gorakhpur chairperson of ISOPAB, and she has represented Foxy in SAFOG. She was the Foxy Vice President 2016 and a committee chair in 2011 to 14, and she has been chairperson UPSR in 2014. She has a lot of awards, but main awards which I would like to tell is about API Abdul Kalam Lifetime Achievement Award. Foxy Award, she has Padma Bhushan, Kamla Bai Hospital, Dr. R.N. Malhotra, Dr. Durusha, Dr. N.A., Dr. Shailaja Pandit Award for Distinguished Community Work. And twice she has received Dr. Savita Rastogi Award for Best Doctor in UP. She has authored several books of cesarean deliveries, vaginal deliveries, comprehensive textbook OBG, and she has been editor of Safe Motherhood Initiative of Foxy Focus. 3-time Dr. D.C. Datta Prize Award for Best Foxy Publication. And she's been awarded many national, international oration and keynote addresses. And welcome, madam. It's an honor to have you today as our expert for the panel. Our second expert is Dr. Archana Baser from Madhya Pradesh. She was the Vice President Foxy 2020 and Organizing Secretary of AICOG 2021 Indore. She's a consultant obstetrician gynecologist director at Akash Hospital Indore. And she is the Guinness World Record holder of removing the largest uterine tumor, which is quite interesting, and fellow representative of AICC, RCOG West Zone, Imaging Scientific Committee Chair of CEFOG, And she was chairperson Foxy Imaging Science Committee 2015-17, organizing secretary ISAR 2016, and she's managing committee member ISAR 18-20 and IH 18-19, ICOG 17-19. Welcome, Dr. Archana.
Thank you,
Our
Dr.
moderator.
Anuradha. Thank you so much.
So, Dr. Archana, I would like you to, introduce our moderator for the day, Dr. Garima Sharma.
Hi, Dr. Archana, and hi,
Hi,
Sarna ma'am.
Seema, my dear friend. How are you today?
Good, 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 good. Hi,
Good.
Garima.
Yes, I am really proud, privileged to really introduce my lovely and my dear Garima Sharma. I think I have seen her grow, and Garima is a managing committee member of ISAR, recently elected, and she's very knowledgeable. She's medical director of Eva Care Plus Fertility and Complete Women Healthcare Center, Mumbai. She is managing council member of Maharashtra State chapter of ISAR, gold medalist. She is MS Afghani from GS Medical College. She has received many awards, amongst which Dr. Manish Bankar Award, ISAR Youth Icon Award, Crushed and Sonu Sharier Best Youth Council Award. I think she is a very, very, a young, dynamic Isarian. And really, I'm looking forward to her moderating the session. So, Garima, welcome on this podium as a moderator.
Thank you, madam, and really thank you for those kind words. And you truly have seen me growing as a child from childhood
So,
till
Dr. Garima, welcome.
Can I
Our
have
panelists. Yeah. Dr. Garima, can you please introduce your panelists? Dr. Baswaraj Devar Shetty.
Can I have the CVs, please? So at the outset, my thanks to Dr. Seema Pande and Dr. Anuradha Khar for coming up with such a topic like Tubal factor, where we all run away from as academicians. But if picked up early, this is one of the best prognosis fertility treatments. And today, to throw the light, I have my esteemed panelist with Dr. Basavraj Devara Shetty, who's the director at Vishwas Fertility and Gynecology Center at Bangalore. And he has been the assistant professor at Basev Shevram Medical College and worked in National Health Services UK from 24 to 2010 and various articles in index journals and faculty for state and national conferences. Welcome, Dr. Basavraj. Can I have the next CV, please? Dr. Arshi Iqbal, Director for Arshi Fertility and IVF Research Institute of Kota, Vice Chair for Person Rajasthan ISAR from 23 till date, and Joint Secretary Rajasthan ISAR 2021 till 22. Lot of awards to her credit with District Administration Award 2023 and ISAR Appreciation Award 2023 as a special accolade. Welcome, madam. Can I have the next CV, please? Dr. Mahesh Koregal, we all know him. He's the senior infertility and IVF specialist at Nova IVF at Bangalore with exclusive infertility and IVF practice for more than 17 years across India and Africa. And he has held various important positions in the Karnataka Association of Obs and Gynec, Vice President of Bangalore Society of OBGY, Honorary Treasurer of Bangalore Society of OBGY. He has also been the current Executive Committee member of ISAR 2019 to 2021 and member of Foxy Endoscopy Committee. He's been the teacher for former assistant professor at Belgavi and has a lot of academic research papers to his credit. I welcome you, and can I have the next CV, please? Dr. Shilpa Haresh, Senior Gynecologist IVF Specialist from Rajeshri Grandham Foundation Hospital and Rainbow Children Hospital. And she has been the chairperson of ART and Infertility Committee and Reproductive Endocrinology Committee of Karnataka Association and life member for Foxy ISAR. Can I have the next one? Dr. Anu Sadashiv, Consultant Infertility Specialist at Milan, Bangalore. And she has been the teaching faculty for FNB, FRM, and Advanced ART course at Milan and Medline Academics. And her area of interest has been recurrent implantation failure, PCOS, fertility preservation, operative hysteroscopy. We have any more CVs? Dr. Satwik Medkut. He's been fellow of Minimal Access Surgery, fellow of Assisted Reproductive Technology, and consultant OBGY at Medkut Hospital in Belgaum. And he has contributed to a chapter in textbook of fibroid and invited faculty for many national and international conferences. So I welcome my all panelists, and there's Dr. Arunima Halder, who's the consultant in IVF and reproductive medicine at Manipal Hospital, Whitefield, Bangalore. And she has authored several chapters in various textbooks and is a member of ISAR IFS and associate member of RCOG. Yeah. Can I
Dr.
share my
Pragya
screen?
Pande's CV, do we have? Or she's not there?
I cannot see her as of now.
Any-
Yeah. Can I share my slides now?
Yeah, please share your slides. So it's going to be an interesting panel with such learned panelists and experts here.
So at the outset, as I said, that we all run away from tubal factors, but nowadays we all know that tubal blockage, especially in the Indian country, accounts for about 30 to 40% of women's infertility. And amongst them, 10 to 25% of women do have proximal tubal obstruction.
Can
So,
you make the slideshow?
yeah, can I? Okay. Is it visible now?
Yeah.
Yeah, you're right.
Yeah. Okay. Just give me 1 minute, please. So now the ideal strategy for patients with fallopian tube abnormalities who wish to maintain their fertility still continues to be a huge debate. And the surgical procedures, as we were discussing, to evaluate the tubal patency can sometimes bring up surprises like congenital diverticulars, congenital abnormalities, duplications, presence of even your paramesonephric duct residuals or mesonephric duct residuals, and do not know whether there is any connection to the fertility of the woman and how do you really counsel. So the latest advancements in diagnostic methods, clinical and surgical trends for various fallopian tube abnormalities and their effects on fertility are constantly being updated, and that is what today our panelists are going to highlight. With this, we move on to our first case scenario. Now here the couple is with the wife, 32-year-old, husband is 35-year, both IT professionals married for 5 years and now trying for 2 years. The couple has already done 2 cycles of ovulation induction with timed intercourse. The woman is very, very aggressive, and now she has come to you for a second opinion, carrying the husband's report showing twice the findings of oligoasthenospermia, and she demands for an IUI to you. On further probing into her history, you find out the cycles are regular, but then she has been complaining of frequent vaginal infections since a year and on and off lower abdominal pain since a year. A good AMH of 2.9, BMI is normal. You do her transvaginal ultrasound on day 6. She wants to utilize this cycle itself for her fertility treatment. And you see a good ovarian reserve with antral follicle count of 6 and 5 on each side. And endometrium already showing an early triple line pattern with mild free fluid in the POD. So to my panelists, what is your plan of action in this given woman who has directly come to you bombarding the treatment she wants an IUI? Whether you're going to counsel her for further 2 cycles of ovulation induction, you are going to heed in for IUI, or you are going to consider a tubal evaluation and plan accordingly. And how are you really going to counsel this woman? So may I start with our panelists? Can you unmute yourself, Dr.
Hello.
Rashid?
Yeah. Yeah, this is a patient here. Sorry, ma'am, go ahead.
Please.
Ma'am, this patient has AMH is reasonably good, and the age is 32 years. But there is some signs of pelvic infection that is there. So as we know that chlamydia, gonorrhea, these are like one of the most common causes which can lead to tubal factors, tubal blockage. Better is to do tubal patency testing if she is willing for it. If she insists on getting the treatment done, probably go for an induction and time natural contact for 1 more cycle, then follow it up by tubal testing. I would not prefer to do IUI without confirming that the tubes are patent.
How are you going to counsel? Yes, Dr. Rashid, please.
Yeah, if she comes on day 2 and the scan which you are showing of day 6, it says it is having, she was having complaining of pain. So while doing
Since a
the
year.
yeah, so while doing the scan, the sliding sign should be kept in mind. And if it is there, so definitely we should go more in history, whether she's giving a history of dysmenorrhea also, might be associated endometriosis, maybe there, might be. So sliding sign, and might be she might be having PID because she's complaining that she is having pain. So that is also important. And she is already there 5 years infertile. So it is better to investigate her in detail, do HSG, counsel her, don't rush with ovulation induction because already she had taken few cycles. So better, because of endometritis, the pain might be associated. There might be endometritis, which is often seen in chronic patients. So better to investigate, do antibiotic course. Then if you find out all the conclusions are made, then only next cycle decide plan of treatment or anything.
The sliding sign is something that I was looking for. Yes, in either you do a bimanual examination or on probing, if there is a fornical tenderness, you start thinking probably there is a PID or an endometriosis that you are dealing with. Before I proceed ahead, I would still want to have a little opinion from other panelists. What would be the modality of the tubal evaluation for this patient, whether you will be considering an diagnostic modalities like in imaging, or you would probably think of considering a laparohysteroscopy directly for this patient. And with the current scenario where she's too aggressive, she knows that it is my husband, how are you really going to counsel her for these tests?
Good evening, everyone. And Dr. Mahesh here. Thank you for having me here. See, there are two things very clear. So simple HSC will help in this case quite a lot, especially looking at the scenario. HSC will tell whether it's a category 2B. The previous slide you saw, Dr. Manjunath was showing how the category 2B was there with the ampullary dilatation. Along with the TVS, if you try to correlate, you will find there will be some kind of adhesion and loss of the fixed ovary you will see. And that is number one. And if it correlates with the tubal dilatation of that side, it is more likely that tube is definitely scarred and damaged on that side. And I would give both options to the patient. Yes, since she has not tried IUI, yes, couple of IUI cycles can be tried with the caveat that it already tubes looks like they have been compromised. Going ahead with IVF is also an option. Yeah, then we are not pushing for an IVF, but then it's an option. Looking at she being 32 years old and some ovulation induction has not worked out. If tubes were to be fine and even sperm, we are seeing that it is kind of mild oligosthenospermia. So looking at all this scenario, IVF would be a better option. But then, yes, if patient doesn't want to undergo, without wasting much time, couple of IVF cycles can be tried. But then I think looking at the scenario, IVF, she might end up with.
Is anyone willing to proceed
Hello.
directly with a diagnostic laparoscopy here?
I think we have to do a speculum examination because he's complaining of vaginal discharge and lower abdominal pain. So check if there's any active infection, take a swab to rule out chlamydia, and probably if it's symptomatic because it's persisting, we can give a course of antibiotics like, doxycycline and metronidazole for 14 days, along with 1 dose of ceftriaxone, 500 milligrams, to just exclude the infection and treat the infection if it is present. And we would like to see her again after 2 weeks to see whether the symptoms are settled down. And along with that, you can repeat a scan and see how the findings are, whether the ovaries are accessible, or they are adherent to each other, or there is a tenderness. Depending upon that, I think we can consider going for HSG or laparoscopy, depending upon the findings what we see on the scan. And because he's 35, married for 5 years, and history of repeated infections for 1 year, probably we can consider going for HSG or laparoscopy depending upon the scan findings what we see.
So I think we have the basic crux till now is that it is all about individualized first the counseling of this patient about possibility of a PID or a local infection or endometritis or even endometriosis. You give her option whether she's okay to go ahead first with a conservative line of medical management, or she wants to go ahead directly with the diagnostic modality, which again we have a divided opinion wherein some we either do the imaging technique with an HSG or the sonosalpingography, or proceed directly with a tubal HLscopy, especially if you have a sliding sign positive wherein you think that your diagnosis is probably more related towards a PID or endometriosis. Now, the patient decides that I want to go see and treat, so do not waste my time. Please go ahead with the laparoscopy, and you go ahead with laparoscopy.
But
And the findings.
also, can I interrupt?
Yeah, Dr. Anu, please go ahead.
I think also, along with all this, looking at how aggressive they are, mild oligoastenospermia has to be evaluated. His weight, habits, lifestyle modifications to be done, his hormones, local examination, and if needed, a scrotal ultrasound to detect the cause of mild oats. And then give him medical management so that that also improves in the meanwhile when we are doing hysterolaparoscopy to her. To her, we may discuss time to pregnancy in an IUI cycle, the success rate per IUI cycle versus an IVF. So depending on her timeline and choice, we can proceed. For her, if mild oats is getting treated, she can very well go for another 2 to 3 cycles of ovulation induction and time intercourse if the tubes seem healthy on hysterolaparoscopy. If there's no improvement, she can step up accordingly, looking at the success rate and time to pregnancy.
So now you have, while in the meanwhile you have worked on working on the husband, you decide to go ahead with laparoscopy, and you see that the tubes are bilaterally swollen, hyperemic. You see tubovarian adhesions on the right ovarian fossa and perihepatic adhesions, mild free fluid in the PIT, and when you do the CPT, the right tube is blocked and left tube is delayed spill. So how will you now counsel the patient with a tubal pathology, a mild oligoastenospermia, with further cycles of timed intercourse or IUI or straightaway IVF, considering all the parameters?
So I'll go ahead. So in this case, probably now both the tubes are mildly affected. So you will have to counsel one tube is blocked. So other tube is patent. The patient may ask what to do. I have one tube patent. I would want to go ahead with natural trying or IUI. Then we can counsel the patient about ectopic pregnancy in this case and tell her that there is a higher risk of ectopic pregnancy. And probably I would counsel her in terms of direct IVF in this.
Any other difference in opinion over here? So can somebody just throw a light on what would be the percentage of ectopic pregnancy risk in these individuals, and can these individuals still consider IUI cycles? If yes, then maximum how many IUI cycles would you want to go ahead?
She may have a risk of ectopic pregnancy about 8 to 10%. And as Dr. Arunima already outlined, IVF would be the ideal management considering any disease like a PID would affect both the tubes. Even though the right tube is blocked and left is patent, we don't know the functionality of the tube. So if she's keen on trying IUI, after explaining the risk of ectopic and the chances of failure, which success may be lesser than 10% in this case, considering mild oats and tubal disease, she can go ahead with 1 or 2 cycles of IUI. If it fails, she has to prepare herself for IVF.
I think we are all on the same page that considering the age profile of the patient with the male factor, with the tubal factor, both tubes being affected, there is a high probability of the tubal function also taken on a toss, and with a very high risk of ectopic pregnancy, probably IVF is the treatment of choice for this patient rather than even trying 1 or 2 cycles of an IUI. At the end of the day, the call is the patient's with all your tube complications explained and documented. With this, we move to our next, a very commonly seen situation for IVF specialists. So here the couple is 35-year and the husband 38-year, married for 7 years, trying for 3 years. And they've had an ICSI done outside another center for unexplained infertility, and 2 rounds of grade 1 blast transfers have failed. Currently, no embryos have left, and she has come to you with a 3D ultrasound report showing a normal uterus and ovaries, thickness of about 9 millimeter, and a right dilated tubular structure of about 5 centimeter, which is most likely hydrosalpinx. Your periods are regular, AMH is good, HSA is normal, BMI is fine, and there's no other history. So can somebody throw a light? This looks like probably a hydrosalpinx, and what are the causes of hydrosalpinx in our current Indian scenario?
Let me Like I'm from North, and here the chances of tuberculosis, genital tuberculosis, a lot many patients are suffering from this. So if I see a patient with hydrosalpinx, so my mind will click for that also. So I'll try to investigate whether she's having tuberculosis or not. And if she has, so concurrently ATT, whether she had taken, if she had taken, then how many months of ATT has she finished? And if she had not yet started, so maybe I'll start with ATT, send to ATT centers and get it started. And simultaneously, I would like to, as she's already 38, I think. So I will I will try to go for IVF, but after starting ATT, at least for 6 months, she should complete it. And then while during that time, doing a laparoscopy and doing the clipping of the bilateral fallopian tubes and keep the embryos frozen, and then I'll transfer to that.
And a quick word here, Dr. Rashi. Now, how will you proceed with the diagnosis for the tuberculosis for this patient? Because that's something which, as gynecologists, we often have a lot of debate. We are not discussing much about it, but just a quick highlight into what you do in your clinical practice.
We do TB gold test if it is positive. Secondly, this hydrosalpinx, it itself is quite relevant with tuberculosis and the endemic area we are in. So previously in past also, empirically people were starting ATT. Nowadays, TB gold, if it is positive, definitely we have to start. And sometime associated tubercular endometritis is also seen, and the patient give the history of scanty menses or oligomenorrhea associated is there, and they give a history that previously we have 5 days flow and now it is only spotting is there, or a day or two flow is only there. So a good history and investigation does work. And then while doing laparoscopy, we see the picture of usually granulomas are seen on tubes, which I have regularly seen on my laparoscopy operation.
To add to this, ma'am, I think detailed hysteroscopy also is equally important in this case.
Yeah, definitely, hysterolaparoscopy.
So my question here to the panelist is, if we reverse the whole treatment, that is, we go ahead first with the laparoscopic clipping, we take a biopsy, send it to the labs, and then find out that the TB on the histopathology has come out to be positive, treat her. How many of our esteemed panelists would want to first do the TB testing through the routine tests, then go ahead with the ATT if there is a TB detected, followed by a hysterolaparoscopy, and then probably the IVF stimulation and embryo transfer, or the second round? And if there is any drawback of doing the salpingectomy 6 months in ahead?
If we are not diagnosing it, sometimes in few cases, if we are not diagnosing it and we go for laparoscopy, sometimes the wound does not heal. This
also,
is,
please go ahead.
So it is better to do all the investigations, and if it is coming positive, then better start with ATT. Go ahead with what I do. Maybe you have different way. Then do laparoscopy after a few months, like 6 months. If I need to give during completion of 6th month, I'll do the laparoscopy, do the clipping, and do everything.
So it is generally advisable that if you have to really do a tubal clipping before an IVF stimulation, it should be just done as close to the IVF stimulation because of a possible also decline in the ovarian reserve. Considering this woman is 35, we really do not know in next 6 months to a year's window how is her ovarian function going to show us. So I think all of us would prefer to rule out tuberculosis. While we are also ruling out tuberculosis, there for hydrosalpinx, one of the other causes in the rest of the country is chlamydia and the gonorrhea infection. So my next question is, just on the ultrasound, we have seen that the hypersalpinx is there and the patient is just not ready to go ahead with the diagnostic tests of the tuberculosis. Would we directly jump to empirical treatment for any STDs or counsel her for further evaluation?
Counselor.
Any variation here?
Counselor and then give treatment.
Yeah. So how will you counsel this couple about prognosis for her next live intrauterine pregnancy with the hydrosalpinx in situ? Dr. Mahesh, Dr. Basavraj.
there is a possibility of miscarriage in these cases wherein there is a hydrosalpinx along with the pregnancy. If it has occurred, there could still be a possibility that there could be miscarriage, and there could be possibility of ectopic pregnancy in this situation, which we have to remember and how to have the outlook.
And anything else that we... Yes, please go ahead, Dr. Basavraj.
No, we have to consider we have to consider importance of hydrosalpinx and the reduced success rate, and you have to consider that it is important to do, because I think she has done one IVF and 2 embryo transfers.
2 embryo transfers.
Yeah, so it is important that we consider and say that it does improve the success rate by clipping or removing the hydrosalpinx. I think because she's 30, I think I forgot the age. She's 35, right? She's 35 and
35.
yeah. So I forgot about the reserve. So depending upon that, we can clip it or we can do salpingectomy depending upon the egg reserve. So if the egg reserve is really good, we can go for salpingectomy, or if the egg reserve is less, we can just clip it and then go for IVF treatment.
So can I make
yes,
a point here?
Please go ahead, Dr. Shilpa.
The thing is that she's undergone already things, and there's a hydrosalpinx. Now, you treat it, supposing it's non-tubercular, treat her with good course of antibiotics. Sometimes these swollen tubes may shrink a bit. But if it is pure hydrosalpinx, it will not vanish. So treat her with antibiotics. She has undergone one egg pickup earlier. I think I would like to do an egg pickup first, make the embryos, freeze the embryos, and then do the laparoscopy, because that will, I will not be interfering with the blood supply or anything. So we'll have good number of eggs got, but only if the hydrosalpinx is, if technically egg pickup is possible with that hydrosalpinx, and that is little away and it doesn't come in your way, because we can't puncture the hydrosalpinx. So I would do an egg pickup first and make embryos, freeze them, go to the hydrosalpinx clipping at the second month or third month, and then do the frozen embryo transfer.
So are there any criterias which define in terms of your visibility of the hydrosalpinx, in terms of the size of the hydrosalpinx, that you really need to treat it, or you are going to treat all cases of hydrosalpinx documented on an ultrasound?
Garima, just before you ask that or tell that, I just wanted to know regarding clipping, or if I have missed it.
I am going to take that a little later.
Okay.
We have not reached there.
Anything more than 3 centimeter, we would like to do clipping or salpingectomy.
So this brings me to the another question, as Dr. Seema has also been asking. What is the ideal treatment, whether it is salpingectomy, clipping, or Western world doing the proximal tubal obstruction? So forget about the second one, the third one. Let's talk about salpingostomy or the clipping on versus salpingectomy.
Depends upon the reserve actually. If the reserve is good. So if the reserve is good, so and if it is easily accessible, there is no significant additions, then salpingectomy can be done. But if the reserve is borderline or low, it is better to always clip it and go ahead for IVF treatment. That's the best way to counsel them.
Any other difference of opinion over here? Salpingectomy versus your salpingostomy.
There is always a risk of abscess if we leave hydrosalpinx. So if the reserve is good, better to do salpingectomy if it is surgically feasible.
And most of the time, tube masses are there. So it's really difficult to approach the tube, and you can just do salpingectomy. That to some extent can be done.
So now various studies actually have shown that, because, even with a moderate to a low ovarian reserve, the salpingostomy will still come with episodes of recurrence and ectopic pregnancy. The salpingectomy remains the gold standard until and unless you have technically difficulty in doing the salpingectomy, as Dr. Rashi was giving us the clinical scenario of a frozen pelvis, where probably just identifying and clipping of the tube may be your option. But otherwise, in current situation, salpingectomy remains the gold standard. So we have a very nice paper over here in 2019, which also has clearly shown when to do salpingectomy, when to do salpingostomy, and what is your success rate. So It says that the current guidance is the removal of your tube by salpingectomy. Salpingostomy you can consider, but you have to give that the ectopic pregnancy rates are going to be as high as 10%. And as far as assure devices are done, we do not do it in India. But still, again, that comes with its own technical difficulties and the failure. Even your Cochrane reviews and UK NICE guidelines have also said that salpingectomy fares much above the tubal clipping until and unless it's a difficult approach towards your fallopian tubes. Now, when it comes to the counseling, I think if the patient says that I just have a unilateral hydrosalpinx and my other tube is absolutely okay, the hydrosalpinx doesn't look big. What all couple of things that quickly somebody can enumerate are the potential risk factors we have already discussed are going to happen in terms of the next embryo transfer.
So usually tubal infection is usually bilateral, most of the time, even though there is no hydrosalpinx, the tube will be inflamed and it will be usually infected. So first of all, we should inform that there is a reduced success rate with, with the presence of hydrosalpinx with the treatment. And second thing, if she gets even pregnant, there is a risk of ectopic pregnancy in the next the normal looking fallopian tube. So you have to counsel them that the success will be reduced, and also there is a increased risk of around 10% risk of an ectopic pregnancy, even though it is looking normal. So we
Also,
should
there have
mention.
been.
Sorry.
Yeah, please go ahead.
No, that's
So
my
taking
thing. We have to
embryo
counsel them reduce success rate and also basically increase risk of ectopic. And we should encourage her to go ahead with a salpingectomy or tubal occlusion if surgically feasible.
So this is a very nice reproductive fact sheet on hydrosalpinx on the ASRM website, which I think all of us can also design and put it, which clearly documents the potential risk factor of ectopic pregnancy, failed embryo transfer again happening, and also the direct embryotoxic effect of the hydrosalpinx fluid on the embryo, resulting into even your miscarriages. So to counsel the patient for really a salpingectomy is a very, very tedious task. Please always document it whenever you are going to even consider a diagnostic laparoscopy in advance. Never take an on-table consent of a salpingectomy and then do the process. So it has to be a preoperative consent. It becomes still a point of litigation for all of us today if we take an intraoperative consent and go ahead. With this, we move to our third case scenario. Now, the similar situation, wife is 35 years, husband is 38 years, married for 3 years and trying for 2 years. Now, she had a history of a left tubal ectopic pregnancy a year back and she was managed medically. Periods are regular. AMH has started showing a little decline with 2.2 nanogram per ml, normal semen parameters. BMI is here 24.5. But on day 9 of the transvaginal ultrasound, you see an antral follicle count of 4 and 5 on each side, an early triple line pattern and mild free fluid. She comes to you and she is concerned about her trying naturally and her future risk of ectopic pregnancy. So how are you going to counsel her for what is the risk of ectopic pregnancy and what is the modality of treatment for her?
I'll go ahead. So, in this case, we will have to tell her that the chances of a recurrence of ectopic pregnancy in the tube is approximately maybe around 25% or so. It's quite high, and if she is trying naturally, we have to counsel her that trying naturally may lead to ectopic pregnancy, and whenever she misses her period, it has to be monitored very carefully. So that is one thing. Of course, we would like to counsel, I would like to counsel her in terms of IVF, but again, that will become very difficult to counsel initially at the initial stage. But the option of IVF should be available for her because she has had a previous pregnancy. However, if you go ahead with the RCOG guidelines, they do say that there's a good chance of conception naturally even after an ectopic pregnancy is medically managed.
Dr. Mahesh, your viewpoints here?
It's very clear. She's already 35-year-old with one-sided ectopic pregnancy. So there is a good chance that she can have ectopic on the other side also. So then looking at her age and the reserve, I would prefer going ahead with IVF. because not only a chance of ectopic, so endometrium is thin, suggesting that there could be a tubal factor or it could be a some kind of infectious etiology. Maybe I would like to do a hysteroscopy guided testing for the any tuberculosis or any other infection, and then go ahead with the direct IVF cycle without taking risk for another ectopic pregnancy, which could be definitely very high.
Now, when you are going ahead with an IVF, now she comes to you that doctor with the IVF technology, my ectopic success rate is ectopic chance is going to be 0%. Can you assure me that?
No,
So
no,
what
no.
is the
That
percentage?
can
And
never
what
be
are the
seen.
key points when you will be taking care of during the embryo transfer?
Yeah, number one, I would like to transfer the embryos a little bit lower. So maybe 1 centimeter or even still a little bit lower than normal. Number two, I would tell her that still, in spite of doing the best of these things, the other factors are there which can lead to the ectopic pregnancy. Number three, before going at the transfer, I would like to do a hysteroscopy basically to check why she has 6.5 millimeter thin endometrium, as well as if there is some untreated small polyp or septum which might be coming on the way.
Does a single embryo transfer be a better technique over here, or we can consider doing?
Definitely, yes. Definitely, single embryo transfer is the ideal in these kind of people. Especially if it's a TGS tested, it is still better, a higher chance of pregnancy.
So now this patient is still very curious and she asks you, despite doing an IVF, you're still telling me an ectopic pregnancy. Why does an ectopic pregnancy really happen with these cycles?
Yes, the main problem is though we think about the possibility that only the tubes are needed only when the interaction between the sperm and egg happens or embryo is traversing is not there, because there is a possibility that there are some uterine factors, uterine anomalies could be there, or when you're doing an embryo transfer, the small push may push it to the into the fallopian tube, or even the motility. There is some small motility of the uterus or the suction of the fallopian tube might also get into the fallopian tube, or there could be a possibility of embryonic factors also, wherein there is a asynchrony between the embryo and the endometrium dialogue. So all these can lead to ectopic.
I think very nicely and very precisely summarized points by Dr. Mahesh here. And this was a very nice diagram, which flowchart, which I saw about why do we really get the ectopic pregnancies post an IVF uh, transfer, endometrial transfer. And yes, the same situations, that is, you have a known history of a tubal ectopic pregnancy, or in fact, if you look into, there are definitive risk factors, tubal infertility, PID, history of tubal surgery, we all know. But even your techniques like the high volume of transfer media, multiple embryo transfers, the asynchrony, as Dr. Mahesh had already said, and then these are some inconclusive risk factors also which can lead to your higher risk of ectopic pregnancy despite having an IVF, which is your controlled ovarian hyperstimulation, assisted hatching, fresh versus frozen embryo transfer, and if you are doing a very high placement of the embryo, you are doing a day 3 versus a day 5 embryo transfer. So now you have done the self-ICSI cycle for this woman, total 5 blastocyst grade 1 performed. You advised her for a single embryo transfer, but then she's adamant she wants 2 embryos. With due risk of ectopic pregnancy explained, you go ahead with the double embryo transfer. The first beta HCG comes out to be 580. The repeat beta HCG 48 hours later is 1450 and your progesterone levels are 15. 4 days later, you do the beta HCG is 2700 and then you decide to go ahead with the scan to rule out an ectopic pregnancy. But what you see is a single intrauterine gestation 5 weeks and another sac in the left adnexa with ring of fire sign, left tubal ectopic pregnancy. Something very rare, but one of the most, I think, nightmares of IVF specialist, heterotopic pregnancy. So can anyone put an highlight into how are you now going to counsel and manage this patient and try and preserve the intrauterine pregnancy?
Yes, it's a heterotropic pregnancy. So this is a very difficult situation to counsel the patient as such, even though it is rare, but it does happen. What can be done is we can wait for a few days, monitor the beta HCG. Definitely beta HCG all that is growing. See how is the growth, keep her on close monitoring. But if you're suspecting it is or impending rupture, or if you're going up to 4 weeks, 5 weeks plus, then definitely I would take her up for a laparoscopy, do a salpingectomy, and then try to counsel them about the risk of the procedure that she may end up with an abortion altogether, but the surgery needs to be done.
Any other way of dealing with this case?
I think I'll go directly for operative laparoscopy. I don't think I'll wait and monitor. Direct laparoscopy and procedure will be my line of treatment.
So, are there any guidelines which suggest that you have to undergo laparoscopy, or there can be also transvaginal guided procedures under the specialist hands for introduction of some kind of feticides? Can that also be done in these cases? And what is the survival recurrence rate of heterotopic pregnancy in the subsequent cycle? Dr. Mahesh, any risk for further heterotopic pregnancies, and what additionally you will be doing in the next cycle?
You would better clip the tubes before taking up.
Yeah, salpingectomy would be a better option. That is number one. Number two, single embryo transfer is always advisable.
A unilateral salpingectomy, or you will consider doing a bilateral here?
Bilateral is
Both,
always
both.
Yeah.
Or just clipping.
Yeah, either ways, but salpingectomy still remains a better option.
Yeah, better option.
Okay. So I think we have covered the major scenarios over here, which is the day-to-day situations which we encounter when it comes to tubal factors and its impact. I would now like to have one quick take-home message from all our panelists about the tubal factors and their management.
Basically, the tubes HSC needs to be read by you. It's a basic test. And most of the times it gives an idea about the health of the tube. Health of the tubes, I mean to say, it is not just a spill. Where is the spill? Somewhere up it will be kindly adherent tube, or it will be a dilated the distal end. So all these things you have to notice, not just to read the radiologist report. I feel all gynecologists should make a practice of reading it. Any doubts they should discuss with their friend who is a fertility specialist, because the HSC will reveal almost 70 to 80% of the things. And then if you read it yourself, you'll find a lot of surprises. And uterine factors like a septate uterus and even small polyps can also be seen. And the peritubal adhesions, localized pill, intravasation of the dye, lymphatic intravasation, so many things you can make out. So if you see the HSC well, I had a whole presentation on HSC. So if you read it well, I think most of the times you can go directly to the next step without wasting age and time of the patient.
Can I have Dr. Satvik?
Yes. So you want the day-to-day practice, I think primarily focus more on the ovarian reserve and the ovarian factors and other things. Tubal factors often gets ignored, so we have to focus on it. And one important thing that we need to see is it is not just the spill that is there, whether the tube is blocked or not blocked. It is very difficult to evaluate the functioning of the tubes. So the inner ciliary lining and the functioning of the mucosal lining is very difficult to evaluate. We need to explain this to the patients when they come for counseling in these cases.
Dr. Shilpa, Dr. Rashi.
A PID prevention is better than cure. Once tubes damaged, very difficult to revive them back. We end up doing IUIs or IVF and associated risk. So counseling should go towards that for young girls.
Along with the HSG, the beautiful insights that Mahesh already told, our ultrasound that we are doing regularly during her OITI cycles can give us a lot of insights, like minimal free fluid in POD or the tubo-ovarian relationship. If the ovaries are stuck high up lateral pelvic wall or stuck behind the uterus, they can tell there are adhesions due to some reasons. So the tubo-ovarian relationship is hampered. And the ovarian mobility, site-specific tenderness, anterior and posterior compartment sliding sign can give us an idea. We can even do SIS to detect flow, the spill, and where it is actually falling. So all these can give us an idea whether to go ahead with hysterolaparoscopy and then decide on IUIs or straight away go ahead with IVF. Because if tubes are not healthy, none of our IUI or TI cycles are going to work. It's just going to waste our time.
Yeah. So as the previous speakers told, I think it's important to evaluate the ovarian reserve, the semen analysis, and the most important is the scan actually, as Dr. Anu was telling. So scan is important to know whether ovaries are free or accessible, adherent, endometriosis. Depending upon that, I think we have to choose whether you have to do HSG or you have to do laparoscopy before we go for treatment.
I would like to add with ABCD, like A should be a very good history taking. We should talk to the couple in detail. So a lot of symptoms comes to us with that, and we can come to a conclusion. Secondly, a good examination, whether the patient has come after showing 10 doctors, but you take it as first doctor, and you should always do a speculum examination, because most of the patient are having cervicitis and chronic PID, which you easily catch up by doing a PS. Thirdly, you should do your own ultrasound. You can see a lot on ultrasound. You can diagnose a lot. So these three things will make you move in the direction what you need to further follow, and then investigations can go on.
मेरा पर्स किधर है?
I think I have one take-home message that I think it's our job to educate the young people about ectopic pregnancy. Though no, they don't know about ectopic pregnancy. They think their beta HCG is positive, and they're very happy about it. The thing that we should find the location of the pregnancy, even if it is early pregnancy, that's very important. This is what I have always tried to counsel the young generation. They don't understand this. Probably this will be a good thing to tell them now, to counsel them when we talk about the chlamydial infections or all these PID related things.
So you are right, doctor. And whenever you have a patient where you see hydrosalpinx or tubes are inflamed or chronically bad or anything, you should always counsel parallelly whether you are going for conservative management or ovulation induction, that there might be a chance of ectopic. And if she conceives, you should be vigilant about it, because nowadays ectopic it is so easy to treat. Medical management is easy. So definitely it is our part also to guide the patient and manage the patient properly.
So I think wonderful take-home messages, and to just quickly summarize all the take-home messages, right from your history to your examination is extremely, extremely important. We should not be forgetting about the importance of post speculum and bimanual examinations. Counsel, and please go ahead with the examination. Doing your own ultrasounds. Yes, we know that laparoscopy is the gold standard, but that doesn't underestimate the importance of doing the basic HST either by your own self, or at least the bare minimum of seeing the image and then interpreting the image and making the plan of action. When it comes to hydrosalpinx management or a patient with a previous tubal known factor like an ectopic pregnancy, please do counsel her preoperatively for bilateral salpingectomy. Also, when you are going ahead with embryo transfers in these patients, a single blast embryo transfer under a USG guidance with little lower placement in the frozen embryo transfer cycles will prevent you with heterotopics and untoward ectopics. And last of all, the day you detect your beta HCG, please do your scans by your own self by the 4th and the 5th week. Look into your adnexa, because that's the most common time when we miss onto heterotopic pregnancies. So with this, I would like to conclude that with a very famous quote by Steve Jobs: learn continually, because there's always one more thing to learn. And I thank all my esteemed panelists. And can I also now have one take-home message from Dr. Archana Basir? Madam Mr. Dr. Seema, Dr. Anuradha, take-home messages from you.
So my take-home message is more on a community level, actually. Ectopic, if it has to happen, it will happen. Let's go into adolescents and school and college going students. Safe sex, use of barrier contraception, because nowadays things have changed, and there's a lot of premarital sexual intercourse happening. And I think that safe sex should be taught at school level and college level to all the people. Also, for us, for doctors and IVF specialists, gynecologists, I have one message, that let's not hesitate in doing the first pregnancy ultrasound as early as possible. What I am generally seeing is patient comes at 2 months, 2.5 months to get the first pregnancy scan done, and we do see the ectopic, and she's gone beyond the stage of treating it medically, and we have to do a laparoscopy. So early ultrasound, as soon as 1500 beta HCG crosses, vaginal ultrasound, locate the sac, and then you are careful. Also, repeat the scan after 2 weeks at least, because sometimes heterotypic pregnancy is missed on the first ultrasound because the sac may be small, there may be discrepancy in the two sacs. So do one scan as early as possible, maybe around 5.5 weeks, 5 to 5.5 weeks, locate the sac, another scan 2 weeks later, and then check, rule out any simultaneous ectopic. That is my message to everyone. Thank you so much. So thank you so much, Dr. Garima. Thank you so much, our experts of the day, Dr. Archana and um, uh, Dr. I think Dr. Sujata could not join. But anyways, thank you, Dr. Sadhna Gupta. Dr. Sujata is the Vice President of ISAR at present, and she is practicing in Odisha. And she was instrumental in holding a wonderful ISAR conference at Bhubaneswar 2 years back. And I thank Dr. Baswaraj, Dr. Arshi Iqbal, Dr. Mahesh, Dr. Shilpa, Dr. Anu Sadashiv, Dr. Satvik, Dr. Pragya Pande, Dr. Arunama Haldar. I big thank you to Dr. Manjunath S for this wonderful lecture. I'm really impressed. I'm so happy after I listened to that age-linked tubal changes. Dr. Shahnaz, thank you so much, Dr. Vanita. And I thank all of you, because with one message on WhatsApp or one phone call, all of you agreed to be a part of this webinar. And this webinar we are doing after 2 years. I'm very happy to have you all, and we will continue this knowledge, our series of spreading knowledge, inside series, and an evening with Isarians has been wonderful. A big thank you for Dr. Seema Pande.
Anu.
1 second. And a big thank you to Corona Remedies First, who gave us this platform. And I would like Dr. Seema to conclude this.
Yes. Thank you, Anu. And uh, guys, I hope this first webinar of our season 2 has made you learn something new. As we were discussing, uh, like genius people, they think alike. Me and Anu found the same thing. Relation of age to tubal factor. Outstanding, Manju.
Outstanding.
You have just made our day today. And this was first time I started thinking on those lines of epigenetic changes. Yes, that is somewhere in back of our mind. But with age, tubes getting shrunken or getting lengthened, that was a common sense, but we never could think about it. So it was really something. I hope our audience, they got benefited by this webinar of today. There were certain technical glitches since this was the first time today. In future onwards, you are not going to face those things, those difficulties. We'll look into it. And thank you, Core Connect, for giving us this platform. Thank you, audience. Good evening, goodbye, Isarians, and all our esteemed faculty. Thank you so much. As we say bye bye, good night, Shabba Khair.
Thank you, organizers,
Thank
for
you, esteemed faculty
insightful
members.
seminar.
Thank you
Thank
so
you,
much.
Thank you,
everyone.
everyone.
Thank you, everyone.
Thank you. Thank you, everyone.
So
Bye.
thank you. Thank you.
Garima, excellent panel moderation.
Yeah, beautifully done.
Thank you.
So I thank everyone, and namaskar, salam, namaste, and sat sri akal. This is Dr.
Bye-bye.
Seema's dialogue, because Dr. Shahnaz is from Srinagar, and salam to you. Thank you so much.
Walaikum salam. Walaikum salam. Bye-bye.
You're so pretty.
Bye.
So we
It was an honor to be a part of this event.
can we go off live now? Corona?
Sure.
Are they
Yes,
there?
ma'am. Sure. We will go off. Thank you so much, Anuradha ma'am. Thank you,
How
Seema
many
ma'am.
how many
हाँ पहले
people
ऑफ
could
कर
join?
दीजिए ऑनलाइन को ऑफ कर दीजिए लेट्स गो ऑफलाइन